All right, let's dive right into our topic today, purulent parotitis. Now, this is a condition that, while you might not see it every day, presents some really unique diagnostic and therapeutic challenges that demand a very precise, evidence-based approach.
So, here's our roadmap for this explainer. We'll start by defining the disease and how it's different from other conditions. Then we'll get into pathogen identification, how to manage it with the right dosing, cover some special cases, talk about potential complications, and then wrap it all up with a clinical case study.
Okay, let's kick things off with Section 1, Understanding the Disease and its Key Distinctions. So what exactly is purulent parotitis? Well, it all boils down to one simple but absolutely critical feature, the presence of purulent exudates, pus. This one characteristic is what fundamentally separates it from all other types of parotid inflammation. It's the whole ballgame.
Think of this as the first major fork in the road for diagnosis. On one path, you have purulent parotitis. It's bacterial, there's pus, and it demands antibiotics. On the other path, you have viral parotitis, like mumps. There's no pus, and it typically just gets better with symptomatic care. So spotting that pus is the essential first step that dictates the entire treatment plan.
All right, the source material actually had a little bit of microbiology humor for us, so here we go. Why did the bacterium break up with the fungus? Because there wasn't enough room for their relationship to grow. Okay, now back to the serious clinical stuff. On to Section 2. This is all about hunting down the culprit, the pathogen identification and testing workflow.
So, how do we actually figure out what we're fighting? It's a really logical process, kind of a cascade. Step 1, you've got to get a sample of that purulent material. Then, a gram stain can give you some immediate early clues. Next, you culture it to actually grow and definitively ID the organism. You might also consider using molecular tools like PCR, especially for those tricky-to-culture bugs. And finally, the crucial last step, susceptibility testing. This tells you which antibiotics will actually work.
Now, here's a really key insight. These infections often don't just appear out of nowhere. They tend to spread from a nearby source. So if the infection is coming from the ear, you might be thinking about bugs like Aureus or Pseudomonas. If it's coming from the throat, you're thinking more about anaerobes like Fusobacterium necrophorum. Figuring out where it started is a huge clue for picking the right initial antibiotic. Okay, Section 3. We've identified the bug. Now how do we treat it? Let's get into management and dosing. This table really paints a picture of how we escalate our attack. For a common bug, like S. aureus, something like flucloxacillin is a great go-to. But for a really nasty, necrotizing infection with multiple bugs, you've got to bring out the big guns, like meropenem. And for even more complex situations, like a liver abscess or a systemic fungal infection, the regimens get even more specialized. It just underscores how you have to tailor the therapy to the specific situation. Now, this is a point I really want to drive home. Antibiotics alone are often not going to cut it. For a full-blown abscess, surgical drainage is pretty much non-negotiable. Think of that collection of pus like a fortress. It has walls, an acidic environment. It's just really hard for antibiotics to get in there and do their job. You have to get rid of that source material for the antimicrobial therapy to have a fighting chance. Moving on to Section 4, where we'll cover some special considerations, some important nuances you need to be aware of. So there are a few special situations to keep in mind. First up, kids. Dosing is always based on their weight, and you have to think about a slightly different set of bugs. Then there's public health. The parotitis itself might not need to be reported, but if it's caused by something like diphtheria, well, that definitely is. And of course, from a clinical standpoint, with all that purulent material, standard infection control precautions are absolutely essential. And now for Section 5. This is where we talk about what happens when things go wrong. Let's look at the profound risks of an uncontrolled infection. If you don't get this local infection under control, it can go on a road trip through the bloodstream. This can lead to bacteremia, which has a high mortality rate, or it can set up shop somewhere else in the body, causing things like osteomyelitis, septic arthritis, or even endocarditis. And on top of that, if the bug is a strain that produces toxins, like some S. aureus, you could be looking at toxic shock syndrome. And then there's this: descending necrotizing mediastinitis. Honestly, this is probably the most feared complication, and for good reason. It's a life-threatening emergency where a severe throat infection literally tracks down through the tissues of the neck and straight into the chest cavity. The mortality rate is devastatingly high.
Okay, to wrap things up, let's put all this knowledge into practice. Time for our clinical application in Section 6.
All right, picture this. A patient walks in with a swollen parotid gland. Right away, as we've been saying this whole time, your mind has to go to that first crucial fork in the road. Is this viral or is it bacterial? Because that one decision changes everything that comes next.
So, first question for you. Thinking back to what we've covered, what's a classic feature of Mumps parotitis? Is it A, pus, B, swelling on just one side, C, that you can just treat the symptoms, or D, that it's caused by Staph aureus? And the answer is C. Yep, symptomatic treatment is typically all you need. Remember, mumps is viral, so it's non-purulent, and it gets better on its own. No antibiotics needed. Making that distinction is absolutely critical. Okay, next up. Let's say you have a patient with a severe case of purulent parotitis, and you suspect it came from a throat infection. Which of these bugs should be high on your list for initial empiric coverage? Is it A, B, C, or D? The correct answer here is C, Fusobacterium necrophorum. As we talked about, this particular anaerobe is a major player in severe pharyngeal infections, and it loves to spread to nearby structures like the parotid. The other options just aren't typical culprits here. And we'll leave you with this final thought to chew on. As antimicrobial resistance continues to evolve, and it is, how are we going to have to adapt our empiric treatment strategies for this infection to stay effective? That's a critical challenge we face across all serious bacterial infections. Thanks for joining this explainer.